want to thank you for coming to our Creepy Crawly Scary Thing presentation this afternoon. Thank you, Pace, for allowing us to do a multidisciplinary approach to these stings and spider bites. I'd like to introduce Dr. Yervati, Al Yervati. He's the professor and department chair of surgery. I'd like to introduce Dr. Patrick Clay. He is one of our pharmacy professors. And I am Jan Jowett, the director of nursing. So again, thank you for attending our presentation. I'd also like to welcome our online participants. Thank you. As I stated initially, we're going to approach this in a multidisciplinary approach from a nursing perspective, surgical intervention and pharmaceutical intervention. It's not often that these stings and bites result in surgical intervention. However, it can occur. So we're going to approach this from a multidisciplinary approach this afternoon. Today's objectives, hopefully we will be distinguishing the different species of snakes and scorpions and spiders that can cause envenomation in your community, in our community, as well as our region. Certainly compare and contrast local reactions and systemic reactions in patients who present with envenomation. Formulate treatment strategies for patients with snake, scorpion, and spider bites and stings. Consider a differential diagnosis of community-acquired MRSA in patients presenting with symptoms of a spider bite.
So we're going to start off with spiders. And interesting fact that there are nearly 900 different species of spiders within the state of Texas. And out of these, only 2 species are seriously poisonous to humans, and that's the brown recluse and the widow spiders. There's a lot of other spider species that can cause a considerable amount of painful bite, similar to bee sting, but few individuals suffer significant morbidity from this. The first one we're going to talk about is an interesting a spider called Lacrodectus mactans, or the southern black widow spider. It's a highly venomous species of spider. Has a significant red coloring, and the fact that the female has the ability that after reproduction they'll kill off their male. Interesting fact. Hence the term the black widow. The venom is seldom fatal to healthy humans. However, it can cause considerable amount of discomfort. This is a picture showing the black widow spider and carrying its egg casing with it. And then certainly the very classic picture of this of the hourglass type of thing. I'll warn you that you can find these around your pool, like in your pool skimmer. They like to be underneath there. They certainly like to be in the garden area and so forth. So really be cognizant, because they're very, very profoundly found in this area of North Texas. In nursing management, we'll turn this over to Jan.
Okay, from a nursing standpoint, when you first when a patient presents, you want to take the chief complaint. You want to ask the appropriate questions. Appropriate questions meaning what, when, where, how, why. Those you want to make sure you're all inclusive in your documentation when taking the chief complaint from the patient. Don't necessarily assume it's a spider bite. You want to make sure that the questions that you pose to the patient are objective in nature, and just don't assume that it is a spider bite, unless, of course, they have witnessed the bite themselves. In some cases, nursing, don't be surprised that the patient will present with the insect. So don't be alarmed. Just keep it in the jar. Don't pick it out, play with it, anything of that nature. But it certainly helps with the diagnosis and treatment if the patient does present with the spider itself. We do not encourage that, because it is dangerous to handle the insects, even if you're bitten or stung with one of them. Don't rule out other possibilities. A lot of moms in particular, I hear, oh, my boy was bitten by a spider, and we know it was a spider because now it's red, and we're afraid that we're going to lose a limb, and so forth and so on. Don't just assume. You want to make sure that you take all appropriate vital signs, and again, ask the appropriate questions to ensure that it is truly a spider bite, and not maybe a helmet-to-helmet infection from high school boys, or different things, head lice, different things that you might see in children. Certainly you want to report the findings to your provider or your physician, depending on where you're working and in the setting that you're in. And document your findings. From a nursing standpoint, you document objectively. You don't put in a spider bite. You want to document in such a fashion that you describe the area. It's circular in nature. It's red. It's erythematous, along with your vital signs. And certainly don't forget the pain scale. You want to see what kind of pain an individual is having from this kind of bite. Symptoms usually occur within 20 minutes to an hour after being bitten by one of these spiders. This particular spider poses large muscle group aches in your quads and your abdomen, and some weakness, and sometimes can mimic a flu-like symptom. So if sometimes you might say, oh, I have the flu, but without asking the appropriate questions, you might jump to the assumption of influenza or some other ailment rather than a spider bite. So we just don't want to hop into the conclusions of a situation without having proper documentation. It's rare to die from a widow bite. However, it has occurred, and typically we see this in the very young, the babies that are playing outside and under the windowsills and looking in the swimming pool and things of that nature, and your elderly population with a decreased immune system. So we want to be careful and watch for those. Just a little bit of trivia here. The venom of the black widow is being tested to treat erectile dysfunction. So we're hoping something from the venom can be productive in other areas. Once bitten by or stung by a spider or a scorpion, or even bitten by a snake, you want to make sure if you're bitten or stung on the hand or other extremity like your feet or toes, you want to take off any jewelry, any anklets, toe rings, bracelets, things of that nature, because swelling will occur, and most likely, and you don't want to have any circulation decreased because of the swelling with a ring or a bracelet or a watch.
Okay, as far as surgical management, you can get the extreme of an erythema shown in the picture on the top left, to even on the hand showing evidence of some superficial necrosis being the second picture. And then finally the bottom picture showing significant necrosis of the extremity due to this deep-seated problem. So certainly, a lot of times this is a very localized type of a reaction. More of the systemic stuff will be the muscle aches, and it's a very classic description of the abdominal complaint, of the severe abdominal cramping with this particular envenomation. And we'll have Dr. Clay talk about some of the pharmacological.
When I was asked to give a presentation and participate in the pharmacological management of these conditions, my first thought was you either swat it, step on it, or shoot it. And they said, no, to treat the patient. And I said, well, I don't necessarily know that it would change my management. For the black widow bite, however, the good news is those bites generally peak in or around September. Maybe that has to do with the fact that pools are closing around that time or not. But in terms of the pharmacological management, there is an antivenom that is available. It is derived from horse serum. Even though there's a very low incidence of anaphylaxis that can occur, it is something that has to be considered in the differential as you begin managing your patient. In this particular antivenom, or in this exposure, if you will, when people are bitten by a black widow, there have been roughly 23,000 incidences reported of people being bitten by black widow. Of those, a little under 10,000 presented with clinically significant symptoms, and of that, only 374 of those actually had an antivenom administered. And so it appears as though this is something that is really reserved for moderate to severe cases, or there may be times in which you're concerned for the prognosis of the patient. It was mentioned immune-compromised, things of that nature. We see the antivenom used more frequently in children under the age of 10, people who present within 24 hours of the symptom, and also they have clinical symptoms present. There have been some reports that this is effective even 90 hours post-bite, but it is recommended to administer this within 2 to 3 days. They can see symptoms begin to be relieved within about a half hour of administration of the antivenom, and which is important for those that are managing health systems in terms of transmission or admission rates from the emergency department. And we do see shorter durations and severity whenever we use the antivenom as opposed to not having it available. Overall, the rate of adverse drug reactions after people receive this is very low, less than 5%. And it is something that has to be infused, and it is done so over the course of an hour at most. So I think our next is actually...
Our second species to talk about is the brown recluse, or Loxosceles reclusa. And significant thing about this particular spider is, by the name, it's very reclusive. So it will hide behind, typically in the garage or so forth, behind cabinets and things. one of our faculty last summer was out in his garden, pulled back where he had some potted plants on, and got bit on the finger. A very significant amount of discomfort to that. Luckily, that person was not a surgeon. So they're typically light to medium brown. The abdomen may have the same color and the classic a violin type thing, giving it the name of the fiddleback, the brown fiddle, or the violin spider. And we've got a picture here to kind of show this particular creature, showing the violin, showing in the pictorial for those of you online, up by the cephalothorax. And certainly this particular spider can cause a lot of havoc to the body. And let's kind of start talking about that.
From the nursing perspective, we want to daily follow up of the wounds for the first 96 hours to assess the possibility and extent of necrosis. We want to apply ice to decrease the pain and swelling, elevate the area if possible, and wash the area thoroughly with cool water and mild soap. We have seen, and certainly avoid any strenuous activity because it can increase your blood flow and increase the spread of the spider's venom into the skin. In these particular situations, we want to recommend that we use acetaminophen or Tylenol for pain relief rather than the aspirins in NSAIDs because they can mask other ailments and cause other issues to the body. We have seen in mythical world, if you will, we don't typically apply heat. In fact, we do not apply heat to the recluse bite. It can cause further skin deterioration and damage to the bitten area. We don't apply steroid creams to the area, such as HC cream or hydrocortisone cream. We don't attempt to remove the spider venom by suction devices or cut an X in the bite area. This goes as well with the snakes. The old-fashioned way of doing things, certainly depending on where you're bitten, is to cut an X over the bite mark and with your mouth or other suction device suck the venom out. Certainly that is not appropriate and can cause further skin deterioration and skin damage, and also envenomation could result from the sucky, if you will. There have been a few anecdotal reports of high voltage, such as a cattle prod or a gun taser type, to the area where you have been bitten. The theory was that if you tase the poison where it's most condensed, you tase it with electricity, then it can counteract, make the venom smaller, if you will, in size, rather than you have a massive amount of venom going through your body. It kind of explodes the venom into smaller doses, and it decreases the chance of getting sick from the bite. However, that is not recommended. Okay, we have seen some people come in with some burn marks, kind of secondary to the cattle prod. So we definitely don't encourage that because, again, it can lead to secondary burns and secondary infections along with the bite itself. So we want to be careful with that. Again, we were in the previous days, we were taught to tie a tourniquet around to decrease the spread of the venom throughout the body. However, we don't tie tourniquets anymore because it decreases the circulation, which in a way it's good because you don't want the venom flying all over your body. However, it decreases the circulation to your limb and can cause decreased blood flow and loss of that limb. So we definitely don't want to tie a tight tourniquet to stop the blood flow.
As far as surgical management, you can get anything from a raised bulla shown in this picture here, a very localized area. The problem with this particular envenomation is there's protein lysis, and there is an influx of very significant inflammatory cytokines and white cells. And that's what causes a lot of the destruction, these very destructive type event. And what happens is then the tissue will start to bull up or swell up and then necrose, and then you get these deep ulcerated lesions that can have secondary infection. But the problem is this significant tissue necrosis and ulceration that one gets. And it can start out very subtly and then expand quite rapidly. And many times you have to do significant surgical debridement to get back to healthy tissue and possible skin grafting on these particular patients. So let's talk about pharmacologic management, and some of this will be controversial as well.
So with respect to treatment and pharmacological management for brown recluse bite, it's going to be primarily symptomatic and supportive. We're using, for fever and itching and things of that nature, you can find a number of over-the-counter and or prescriptive agents for those immediate needs. But in terms of using antibiotics to treat this, and specifically what has been used in the past is dapsone. The evidence to support dapsone, when looked at in a rigorous fashion, doesn't clearly show a benefit, and there is a risk to using dapsone, especially in pediatric patients, especially in those who may have G6PD deficiency, and the risk is hemolysis and methemoglobinemia. But even in those without G6PD deficiency, we can still see an occurrence of methemoglobinemia and hemolysis at the doses that historically have been reported to be used in the treatment of brown recluse bites. And most people, when they're considering dapsone, they would do so in incidences where it's been a moderate or severe case and it is beginning to progress, and it's one of those things where they want to try to do something. And what they've tried is 50 to 100 milligrams twice a day from anywhere from 1 to 2 weeks. And it's just the evidence to support that really is not that readily available. The rationale behind it is its effect on the PMNs. As you mentioned, they get a lot of local inflammation. And their thought is perhaps by attenuating that, we would get some benefit and minimize the severity of it. But again, when it was looked at in a rigorous fashion, that clearly was not the case. As was mentioned before, electroconvulsive therapy is not recommended for dapsone. No matter how long you've been married, don't do electroconvulsive therapy. There have also been studies looking at nitroglycerin paste being applied to it to be applied to it to see what they could do. And it also showed no benefit, and they've even administered or had people undergo hyperbaric oxygen to try to make a difference. And again, there was no clear benefit with that as well.
So I think with this particular envenomation, one of the problems, again, is the very significant tissue necrosis and need for debridement. The interesting thing about dapsone, that was used for leprosy. That was the first use of dapsone, and then someone got the idea because of inhibiting the white cell response that might be applied to this particular envenomation. The next species we're going to talk about is scorpions. They're kind of an interesting group in that there's about 18 species in Texas. Most of them are down by the Big Bend area, Rio Grande area. They can vary in color and so forth. You can even find them up here in North Texas. I found one time one of our cats was playing with something, and certainly there was a scorpion in the house up in South Lake. So they do occur all around. The individual reactions are varied, but it's like a very painful, sharp sting with a local reaction. The description is as if you took a hammer and drove a nail into your hand. That's how localized it is. It is a neurotoxin, and you need to be watched for adverse or allergic reactions depending on where the envenomation occurs. So here's a picture of a classic scorpion, kind of with the tail, which is the stinger. You know, they may kind of grab onto you here with their little pincers, but certainly that's more a way to hold their prey. The big problem is the envenomation back on this on the dorsum here with their stinger. So let's talk about a few things, nursing management.
Okay, from a nursing perspective, we do. If you live in like Wise County or Parker County, somewhere out in the country type areas, or where there's new homes going up, you will certainly see some scorpions. And it's not an absolute death sentence by any form or fashion. It does sting a little bit. I'll briefly tell you, when I was in high school, I was doing some sit-ups in the living room, and we lived out in the big middle of nowhere, essentially. And we would have the burrs, the stickers, as we call them, the real cock burrs that really hurt, not the soft stickers. We would track those in, and Mom would be real thrilled with us. So one evening I had my feet under the couch, and I was doing sit-ups for working out and all that, and I kept hearing a stink, tink, tink every time I'd go up and back down, and I had a tink, tink in my back, and I thought, oh dear, I'm having sit-ups on this sticker in the carpet, right? Well, I finished 150 sit-ups only to turn and see a scorpion there, and I had a huge local reaction on my back, and thank goodness my mother was a nurse, and we got it sorted out. But they are around. They are a little bit scary. They don't hop or jump or anything of that nature. If you see one, either step on it, like Dr. Clay mentioned, or just go on and put it outside. From a nursing perspective, basically what we do for these is, once again, you want to get the accurate information, identify it as a scorpion sting. We can treat with OTCs or over-the-counter, such as Tylenol. You want to observe the patient for anaphylactic reactions. Some individuals are hypersensitive to the venom of a scorpion, so we want to make sure that we just watch for that anaphylactic reaction and be prepared. We want to collect the history again from the patient and assess the wounds and watch for secondary infections, because particularly in little kids, they get their hands on it and scratch it a lot and can create a secondary infection. Antibiotics aren't helpful unless the sting again becomes secondarily infected from picking and scratching. Again, do not cut open the wound or apply suction. And then certainly document your findings. Again, document the location, the color, the size, and the pain scale.
Typically what you see with these, because they'll strike and they can strike again with the stinger, it'll kind of track around, as Jan was saying, depending on how you're getting hit by this particular creature. You get a centralized area of a raised kind of welt, if you will, that's shown in the picture, and then this outline of this very erythematous kind of reactive type area that one gets. Fairly self-limiting, not much as far as needing significant debridement, other than, as stated, for possible IND of an abscess that could form. The interesting thing is, if you take these and deep fry them, then you basically negate the venom, so they're safe to eat. And I haven't seen these at the State Fair of Texas yet, but I'm sure someone will have an idea to put them on. So let's talk about pharmacologic.
So there is a vaccine. There's an immunoglobulin to treat injection, scorpion envenomations, if you will. And the nice thing is that it has been shown to be highly effective. The nice thing also is that it is quicker acting in pediatric cases than it is in adult cases, where we see them begin to get symptom benefit within about 1.25 hours, about an hour and 15 minutes in children. And in adults, we see it in about 2 hours. Now, what's important to remember is, regardless if you use sedatives in the patient, not in the providers, in the patient, it doesn't really affect the improvement of the symptoms. You normally have 3 vials administered over a very short period of time, and then you begin looking for some symptomatic improvement. Now, the onset of significant improvement won't be for over an hour, but if you don't begin to see at least some improvement within that first hour, then it's recommended to go ahead and administer an additional dose. Very low rate of adverse drug reactions with this. We can see some anaphylaxis with it, as we can see with almost any medication out there. It is derived from animals, so there is always a risk for some viral contaminant to be within the product. So there is a very extremely rare incidence or risk for viral contamination with that. And because there is creosol in the formulation, you can also see a reaction locally and potentially some myalgias to occur. But again, those are quite infrequent.
So as we move along here, our next species to talk about is the centipede. It's kind of an interesting creature. Having one pair of legs for the body segment, they can be 6 to 8 inches or even longer and larger. They've got different colorations. Some can be yellowish to orange, very bright looking. It's the pincers that causes the problem, the intense pain. Patients will complain of a burning sensation. The legs do have a needle-like structure at the tip that also can be painful. But the big problem is the pincer. And this shows the usual centipede with these large pincers showing down in the bottom part of the picture, and certainly a nice coloration for those of you that are into bugs and things. Quite a pretty creature. Let's talk a little bit about nursing management, and then we'll cover the other areas.
Again, from a nursing management standpoint, I've been a nurse, I guess, now for 20 years, and I've never seen an actual centipede bite, so I'm a little bit unfamiliar with this particular bite. However, upon my research, we would basically do supportive care, wash the exposed area, and place ice over it, 10 minutes on, 10 minutes off in increments to decrease the swelling and prevent possible damage from the bite. A trip to the emergency room in a centipede situation is not likely unless you do have an anaphylactic or an allergic reaction to the venom of the centipede. Again, we would most likely recommend, say, if an individual were to phone in to the clinic, we'd most likely recommend home care for a centipede bite. Now, that's on the assumption that they know indeed that it's a centipede and not a brown recluse or a black widow or any of the other insects that we've talked about so far.
I have seen centipede in the Army at Fort Hood, and certainly down at Fort Sam at Camp Bullis outside of San Antonio in the latrines, so one would need to be very careful when you're out camping on that. The surgical management, basically you get a very localized reaction, as stated, a very painful, kind of a throbbing type of thing that's fairly self-limiting, and then certainly very minimal tissue damage and so forth from the from the envenomation. So it's more of a localized thing from this particular creature that one would entail. So on pharmacologic?
Well, this was the easiest one to talk about. Jan's already covered it. Basically, there's no antivenom that's available, and you really are just going to do symptoms and supportive care for these individuals. The thing I hadn't mentioned to date is please make sure their tetanus shot is up to date.
So as we run along these different species, next we're going to talk about snakes, and we're specifically going to talk about snakes within the state of Texas. This next slide shows the state of Texas and multiple different species, not geographically distributed on this picture, just to show you all the different species that are available within the state. So the first one we're going to talk about is the rattlesnake. Interestingly enough, there are 10 different species of rattlesnakes in Texas, more than any other state except Arizona. The 3 species that are important are the western diamondback, the prairie, and what's known as the eastern timber or the canebrake type snake. And the western diamondback, interesting enough, you're looking at the Latin name, denotes frightful or grim, and accounts for most of the serious envenomation and poisonings within the state. The interesting thing is that all 3 of the species have basically the same type of neurotoxic active peptide. And then there's an enzymatic factors that also causes significant tissue destruction that destroys the blood vessels and so forth. And that's why you get such a bad problem with these snake bites that are not treated. About a third overall potency in the diamondback than the others, but certainly there's significant problem. This shows a picture of a very significant large rattlesnake here that was captured. Certainly they're around. Probably won't find one in Fort Worth or in the city, but certainly as one gets out to the outlying communities. Interesting thing is that, again, the rattle here, which is the telltale, as this creature is trying to warn you to stay away. They certainly are afraid of you, but if provoked, certainly will strike. If you're out camping and so forth, wearing heavy boots or so forth might prevent a problem, especially walking through the woods. Okay. The next snake to talk about is the coral snake, and I'm going to challenge you to see on these pictures. On the left is the coral snake, which is venomous. On the right is the common milk snake, which is not venomous. Everyone kind of confuses the two, so we've got a little mnemonic for you. Red and yellow, kill a fellow. Red and black, friend of Jack. And many of you probably have heard this growing up or heard this. We live down in the country. So if you look at the stripes, you can tell. So if there's red and yellow, stay away. The other is the broad-banded copperhead. And most of this area in Dallas-Fort Worth is inhabited. There were recent cases that were reported, one in Crawlyville, where a gentleman was struck by a particular copperhead. They've got a very broad-banded head. The tip of the tail can be grayish green to turquoise. And they're considered by some specialists as the broad-banded copperheads are one of the most beautiful of the snakes in north central Texas. However, not everyone agrees with that particular statement. So here's a picture showing the snake. It's got the very significant copper-type head that's shown here. This shows the creature with its mouth open. There's the pit, consider showing, and more of the tighter snout. That shows that indeed it is a venomous type of creature. The fangs are withdrawn, but here are the sacs where the poison and the venomation basically will sit. So on this particular creature. One should kind of the basics. The poisonous snakes shown on this pictorial have a very rounded head. The non-poisonous are a little more rounded, kind of broad base in the triangle. And then, of course, the pit, known as the classic description of a pit viper being this particular type of a way that they're able to sense their prey. So over on the left side picture, for those of you online, shows the copperhead, and on the right is a non-poisonous type snake, kind of common snake. Somewhat difficult sometimes to really determine. So the other one that's interesting is the water moccasin. It's one of the most venomous snakes that we have available in this area. It does occur in DFW, but most of the time the harmless water snake is misidentified for the cottonmouth. You'll hear this over and over. If any of you have ponds or fish ponds, you'll find them in the springtime and so forth. I have a koi pond at my house, and I've taken some very significant looking snakes out that basically look like a cottonmouth, but certainly they're the common water snake. They can deliver a very painful, medically significant bite. Interesting thing is there are not really any real significant fatalities from this. Only about 1 person per year dies in the United States from a cottonmouth. More from rattlesnakes than from cottonmouth. The classic snake has a very broad body shown in this picture, kind of fattish with a head versus the common water snake, which is a little more slender. But both of them kind of have the same kind of color markings that can fool you. This shows the classic mouth open, the cotton term, the cotton mouth term, based on how the mouth looks as this snake is open. But one can see from the picture here, very broad, kind of fatty, kind of a midsection on this particular snake versus on the other. So let's talk about nursing and then pharmacologic.
Okay, from a nursing standpoint, we want to, again, identify and ensure that we have wound management and follow universal precautions from a sterile procedure fashion, including sterile donning of gloves. We certainly don't want to introduce any further bacteria into the wound. We assess the wound for signs and symptoms of infection, and we want to make sure that we're determining a snake bite versus a cellulitis or a staph infection, whether it's a snake bite or secondary to a snake bite, or maybe it's not a snake bite at all. You notice these snakes, if you see the mouth of that cotton mouth, you're too close, okay? They are very, let me just tell you, I grew up in Wise County, and I've seen several of these snakes along my journey, but the cottonmouth is very aggressive, and if you see it in that form, it's very upset and wants you to go bye-bye. Most of the snakes will not just randomly attack you. You really have to be up close and personal. We don't want to scare you away from snakes. Some snakes are quite good for nature and in the food chain and so forth. So they don't just show up in your house and start striking at you. You really have to provoke them. Statistically speaking, more men than women are bitten by snakes, and not so much because of some scientific finding, but because of where they work. You see a lot of cow ranchers and things of that nature, people that are excavating and working oil fields and things of that nature, where it's predominantly male-driven as opposed to a female type of setting. So you see more men typically bitten. Now, we can make assumptions there, I guess, for those men that bring the snake to the ER with them. It's well, I wanted to catch it or kill it or intimidate it. A lot of bites will come from intimidating or trying to catch the snake rather than you just calmly walking around it and leaving it alone. Okay, so be very careful. Immediately, if you have a phone-in patient, or if you're out in the wilderness with your kids hiking, hunting, camping, whatever, immediately you want to keep the victim calm. Again, remove socks and shoes if you're bitten on the ankle due to swelling, or if you're bitten on the hand, you want to again move watches and any type of tourniquet type bracelets or anything of that nature, because swelling definitely will occur with snake bites. Wound management, again, with the sterile procedure, you want to note the type of dressing and the dressing change. Sometimes it's a wet to dry dressing, depending on how the healing of the wound will be recommended by the physician. We want to try to keep the wound, the place of the bite below the heart to decrease the blood flow. We don't want to run out and go for a half marathon run after being bitten by a snake, because, again, it increases blood flow and you don't want the venom to get any quicker throughout the body than absolutely necessary. So definitely keep the patient calm, and I try to get markings from the snake, not the snake itself, but try to identify to some form or fashion, color, length, that type of thing, head shape. Is it a pit viper? Does it have rattles? That kind of thing will be very helpful in the emergency room when they're being treated. Again, it's just best to leave these snakes alone. We have had in our neighborhood in Lost Creek have had several snakes on porches and in potted plants and things of that nature. Typically, you will see an increase in residential area with surrounding new homes going up or farmlands and things of that nature that surround a residential, as well as drought type situations where the snakes are being forced into communities looking for food and water. So you may see some. In fact, someone recently in a city type, I think it was Burleson, had found a copperhead in her home. So you just want to just be careful, make sure your doors are shut, and just be aware of your surroundings. And don't think that just because you live in the city, you wouldn't find a snake. Just be careful of looking for these things, even with spider bites and centipedes. Just be careful where you're putting your hands and feet.
For surgical management, certainly the things that Jan talked about are important. Getting away from the striking distance, because they can strike a second time. And the smaller, younger snakes have more of a problem because they're very aggressive, and they'll inject you with a higher dose of venom than more of a more mature and older snake. Don't cut the bite wound, the old X on the wound. Don't use any type of sucking device. Applying a tourniquet and sticking in a bucket of ice water is not recommended as well. And give them a bunch of alcohol or load them up on Monster drinks or so forth, again, is not advised. What the management is we're going to talk about, we'll talk about the pharmacologic in a second, and the antivenom, and Dr. Clay will go into that in better detail. But local wound care initially, there is sometimes need for debridement of tissue, and then fasciotomy. A fasciotomy is when you make linear incisions down through the skin and down to the fascia, which is the lining that overlies the muscle. Due to the edema that you get, there's so much destruction and so much vascular compromise and thrombosis that you get significant reperfusion edema. So here's a hand showing this very swollen hand where this particular victim was bit on the wrist, and one can see there's just significant amount of edema occurring. Sometimes you'll end up with significant necrosis from that. There was a fasciotomy done along the palmar surface here. That's the incision here to help with that. Certainly this particular person, even once they recover, will have limited mobility of that extremity. And then there's the drastic part of having to do very significant fasciotomy, really opening this up, because these limbs will swell 3 to 4 times the size of what they were. And the problem with that is as the edema occurs, the muscle is encased within its fascia. So then that will decrease the arterial inflow and maybe cause arterial thrombosis. Now with that, then you've inhibited venous outflow. Now you clot out the veins, so now you get a significant problem of both arterial and venous obstruction, which certainly could lead to limb loss. So this particular shows extensive fasciotomy, and then this is a skin graft that's placed to cover that up. So certainly a very significant amount of morbidity with these particular envenomations. Let's talk about pharmacologic.
Well, the good thing is with these particular envenomations, there is now a much improved product on the market for use after a bite. Previously and historically, it was primarily a horse-derived, very, I guess, impure approach, if you will, for treatment. But now with the approval of CroFab that came out not all that long ago, we're able to administer this and feel a little bit more comfortable in terms of anaphylaxis as well as delayed reactions to this. This is a sheep-derived agent that actually used the antibodies from 3 various Crawly, as well as one of the pit vipers. So regardless of the type of rattlesnake, while it's great for you to try to describe what kind of rattlesnake it was, if you can just tell them it's a rattlesnake, it'll be okay. We'll figure it out from there. Don't send somebody out into the woods, no matter if they were the ones who had you get bit or not. There is a starting dose with it that's fairly substantial, and some of the criteria for starting it are based on the symptom, the presentation upon arrival. If it is a moderate symptomatology, or if they've been bitten by a Mojave rattlesnake, or if the serum creatinine is elevated. So even if it's a minor presentation or insignificant clinical, but if it was a Mojave rattlesnake, then you would still use the antivenom. So that one has a little bit of a different toxicity, or I'm sorry, impact, if you will. The elevation of serum creatinine, many times, as was mentioned, you're dealing with people that are working out in very hot, dry environments, and it could be a fact of dehydration. So that's going to be a clinical judgment at your call. If it is a severe envenomation, then you're going to go with 6 to 12 vials. And as we discussed earlier in the Dallas-Fort Worth area, it's Harris Methodist that maintains the antivenom in the area, and there is a very nice system in place to get the antivenom to the hospital that's closest to where that person is going to be arriving. So they will move that. And we have some information on coordination with poison control centers. This is a drug that's reconstituted. It's run in over an hour. You don't have to pre-test for any medication. For allergies, you don't have to give any pre-meds as well. If they begin to get a reaction to it, discontinue the infusion, treat the reaction, and then restart the infusion. You can run it at a slower rate if you need to. You watch them over 1 hour, and if they've stabilized, then that's generally recommended to go ahead and admit at that point. If not, then go ahead and give an additional dose of this. Again, tetanus, pain management, acetaminophen, narcotics, no aspirin or NSAIDs because of the complicating factors of those. Also, if someone is allergic to sheep or papaya, you can't use this. And I even looked between our practice this morning and just now. I don't know why, but papaya apparently is bad for people. I don't know. The other thing is, even within 48 hours, if symptoms begin recurring, you can go ahead and re-administer this. And there is some data to show that even though you would like to get this administered within 3 to 4 hours of a bite, that is considered ideal. It has shown to be beneficial even 3 days post-bite because, as was mentioned, these bites don't generally occur at, what was it, Jungle? Rainforest Cafe in the mall. That's usually not where those snakes are, so they're normally somewhere out in the wilderness. With respect to the coral snakes, which we don't see a great many of, thankfully, there is not an antivenom available. It's primarily a neurotoxic effect, and there is some off-label anecdotal information to suggest that you could use either neostigmine or idrophonium for that. There's some recommendations out there. It's recommended, though, if you have a coral snake bite and you're having to assess it, that you contact someone with expertise in this so that they're able to walk you through the management of that.
So working our way, so the big thing is, number one, avoid contact with any of these creatures. Certainly there are signs and that are real in the state of Texas showing that rattlesnakes are in the area, for those of you that may not pay attention. There's also a state of Texas park sign, poisonous snakes and insects inhabit the area. No surprise. And it's been great doing this presentation as a multidisciplinary approach. It's been great to meet you, and we're open to any questions or comments that one might have.
So this was the promise that if you get in trouble, if you have this occur, by all means, call an expert. They deal with this every day. I spent 4 years at the Oklahoma Poison Control Center. It's always fun to be on the end of those calls. Part of the fun is the fact that you're several hundred miles away from a group of people who were partaking in activities that put them at risk for a snake bite. So any questions that we can answer at this time? So the question is, with respect to the scorpion bite, is there any evidence to suggest that vinegar and baking soda? So those sound like you're trying to adjust the pH of the surface of the skin. To my knowledge, I didn't run across anything that recommended that. I don't know if either one of you saw anything like that.
No, but people have used those particular treatments using vinegar or some type of sodium bicarbonate or that kind of on any bites or stings to reduce that inflammatory initial reaction that you get. Nothing as far as in the literature on that, but there's been a lot of home remedies used with that. Certainly, it's not going to harm you using those kind of treatments. Great. Well, thank you, and like I said, it was great coming.